With all the cuts that are coming from central government to public spending generally, apart from the NHS, patients are going to be that much iller. They're going to be out of work, out of housing, and they're going to be relying even more on the voluntary sector. The NHS has for a long time relied on the voluntary sector, and the local authorities have also done the same. So I'm wondering, how do you envisage the voluntary sector and the local authorities being supported in this deluge of pressure that's going to be on the public through being out of jobs and out of housing?
These are big questions, and I'm not in charge of health policy in the UK, so anything I say is a personal opinion here. I just realized that to the last question, the point I didn't respond to is, how's it going to be implemented? Well, I'm not aware of any plan. It's purely a benchmarking exercise. The information is being put out there saying, if you're not doing this, you should be doing it, get on with it to make your savings, but there is no strategy to actually implement that with resources to back it up, as far as I can determine. And that comes to your point about reliance on the voluntary sector. The key points made this morning about the relationship with local authority budgets and the health budgets. It's been recognised by the transfer of resources over to local authorities, but whether that is going to be enough to avoid major issues, I very much doubt. So underlying all these predictions about 15 to 20 billion being enough to make the savings and still maintain quality is predicated on an estimate of growth in demand, which may turn out to be very much an underestimate. And the type of demand, as you say, may be quite different from the current makeup of demand as we go into a continued, not necessarily a further recession, but certainly difficult economic circumstances for many people. So the data tells us that this will lead to more health problems, and maybe that will eat away the benefits achieved by trying to make services more efficient through the QIP agenda. But I think the worst possible situation would be if we don't try to address the QIP agenda and make those savings, which we can prove will not reduce quality but may in fact improve it. Because if we don't make those savings and we get an avalanche of increased demand on the service of a particularly expensive kind, then the whole thing is just going to be unmanageable. This is somebody who
Meriden Peachy, I'm Director of Public Health in Kent. It was really useful actually seeing a picture of all the evidence, some of the evidence around QIP and what works and what doesn't, and I think that's really helpful. I have a question around alcohol. It comes into your prevention. Alcohol is rising costs in terms of the NHS, it's rising costs in terms of the police, in terms of social care. And I think one of my issues around the whole issue of alcohol is clarity around where exactly are the savings to be had and who should invest. And if we think of the amount of time it takes the police, A&E, urgent care, inpatient admissions, everybody else, and I just wondered if there's any work being done to help clarify that. Because, for example, if the police put a lot of prevention monies in and the NHS save it, and other agencies, to me, alcohol is just such a big issue at the moment. And I'm working on one very small issue, is collection of data in A&E. And it is so hard to get them to collect 3 issues on where the violence happened, what with, and what club or whatever. And the police are waiting in the wings to do something about the licensing of where it is. I'm finding it really difficult to get the A&E to just collect that little bit of data to help us. So I just wondered if you had any more thoughts around the whole issue around how we tackle it. There must be huge savings to be had.
Yeah.
Sorry, thank you, Meriden. Yes, we have, YHEC has done some work on alcohol issues in Scotland, and the previous organisation I used to work for in Scotland has done some work, and there are significant there are significant costs associated, as you say, not just through the health service but through the wider social issues. that are associated with alcohol. The issue, as John pointed out, that we're concerned around is around what prevention actually does in terms of savings for the NHS. Now, obviously, if you can reduce the number of people coming into A&E, then there is a tangible saving to the NHS. But the broader issues about alcohol and admission rates are rising, not just through A&E, but through for people with liver complaints and liver problems. Yes, I mean, all I can say is that there are significant costs attached to it. Whether or not those savings can be transferred into the NHS and tangibly saved is another question, really, I think.
30 seconds, one more question. Sorry, Wendy, you were in the queue there.
Wendy Savage, Keep Our NHS Public. This question of productivity, it seems to me that, like the Nuffield study that they did comparing the 4 nations, it's very crude, isn't it? And it could well be that with more time and more staff, patients are having longer with their clinician to discuss their problems, and that this is an improvement in the quality of the consultation and the treatment, but which doesn't come out in the published data. And I was glad to see that you mentioned that if you look at the waiting list initiative and did that against the growth in numbers, that this matched much more clearly. My second question is, we know from the evidence that the Department of Health gave to the Health Select Committee, which was published in March this year, that they estimated that the cost of the market was 14% of the NHS budget, i.e. £14 billion. So if we stopped having the market tomorrow, we could save £14 billion tomorrow, the next year, etc. And I find it amazing that we've had all these talks from people from the Department of Health. The private sector's hardly been mentioned. And yet they're the only people who have come out and said that the white paper is a good thing because it's going to lead to the denationalisation of the NHS. So what I'd like to say, whilst I've got the microphone, is to all these people here, for God's sake, stand up and fight for this white paper to be defeated.
Well, I sympathise with a lot of what you say there, and the cost of running markets is quite high. And I say this as someone who once taught academic economics, and one of the big things that's missing in a lot of the textbooks of microeconomics is a thing called transactions costs, which is conveniently ignored in markets. And markets are put forward by people who say that the quality rises to the top and the good people succeed because people can choose to go to the right place. But the corollary of that is that markets succeed by destroying wealth for the people who don't actually come to the top. And if that means it destroys your local hospital as opposed to the one in the next town, then maybe from a societal point of view, this isn't probably the best way to allocate resources. I'd like to leave you with one of the conundrums that I see in the white paper, which no one has yet been able to explain to me, is there a role for commissioning in the vision in the white paper? Because on the one hand, you have patient choice, so we can ask our GP to refer us wherever we wish to go to, as long as they are a willing provider. We have a national tariff system which pays the same thing to everybody, so it doesn't matter to the commissioner where we go, it still costs them the same. So why have a contract? Why have a commissioner? And if that's the sort of system we're headed for, the commissioners will in fact be insurance organisations, not active commissioners in the way that we think of them in the market now. And if we think that is the way that services ought to be developed, then, as Wendy said, we ought to think hard about the direction of travel, to use the dreadful jargon, and where people's fallback positions are, because as in all good policy initiatives, they know it's not going to achieve the ideal objectives, targets and so on, but it's going to fall short, and it's looking at where things are going to fall short that we ought to be doing, I think, to guard against serious damage to the provision of services. Thank you very much indeed for being a very good audience.